Shall we start, Dr. Sevanti?
Yes, please.
Yes, you can please take the stage.
Thank you. So, a very good evening to all. We here at Horizon meeting, we are again getting together for a very, very special evening of discussions around cholangiocarcinoma. And as we have been hosting these meetings with help from Priyanka Joshi from Jarurat Care Foundation, and of course, anchored by none other than Professor Milind Javle. Those who have attended and known this meeting have understood that this is a meeting that brings together a global discussion forum. We have India on one side and global experts on the other side coming together into this meeting. And so it's a national, international amalgamation. It's a joining of experts all across the globe, bringing in a focus to cholangiocarcinoma, of course, in India, but bringing in data and discussions from the global forum and global horizon. So I welcome one and all who have joined this evening for an interesting and an academic treat, essentially, because we have amazing speakers this evening from both sides, both from the global experts who are joining us as well as the national experts. So the focus, the conversation reflects our commitment from both sides. It not only brings together the experts and focus on cholangiocarcinoma from an academic perspective, but just because this is a meeting that was envisioned and anchored by Jarurat Care Foundation, I think it brings into perspective that patient advocacy today is ever powerful. And I wish you more power, Priyanka, in bringing this meeting and the cause to a higher level. With that, we will go ahead now, Priyanka. So I would like to quickly introduce Professor Huang Valle, who is our first speaker of the evening. Professor Huang Valle is the CEO of the Cholangiocarcinoma Foundation. And he has served as a professor of medical oncology at the University of Manchester and at the Christie NHS Foundation Trust in Manchester, UK. He also has contributed to landmark studies in cholangiocarcinoma, like the ABC-02 trial. He's published widely over 400 publications. He is published in the Gospel of Medicine, the New England Journal of Medicine, and he's a global leader. Needless to say, he has actually played a role as a pioneer in multiple fields in the cholangiocarcinoma disease as a cause. He's a founding member of the International Biliary Tract Cancer Consortium, and he has established the Christie eNet Center of Excellence for Neuroendocrine Tumors. So whatever I have just said is actually too little in introduction of Dr. Valle. We are truly it's a special occasion for us that you have joined, and with your talk, we envision that we lift this meeting to the next level. So thank you, Professor Valle, for joining us, and the stage is yours. We will be listening in, and all of us can put together questions in the chat box, and of course, one can ask him after his talk as well. Thank you.
Thank you, Dr. Sevanti, for that very kind and generous introduction. I'd also like to thank the whole team at Jarurat Care Foundation for the invitation to come and speak today. It really is an honor and a pleasure. I think it's important, you mentioned patient advocacy, that we all support each other. And here at the Cholangiocarcinoma Foundation, where I'm now the Chief Medical Officer, we really do like to work with other foundations. And it's been a great pleasure to work with Priyanka and her team. So my remit today is to focus on immunotherapy in cholangiocarcinoma, but taking a particular view on it, how much evidence is enough to treat. So first of all, my disclosures. And what I wanted to do on this occasion is focus a little bit more on gallbladder cancer. We talk about biliary tract cancer widely. Of course, that includes intrahepatic, perihilar, and distal cholangiocarcinoma. But we mustn't forget the entity of gallbladder cancer, which is very rare in the US, but much more common in India. And so the lens that I'm taking today is to specifically focus on gallbladder cancer, which we know India is a hotspot. Those of you who don't know me may not know that I originally come from Peru in South America. And Peru, Chile, Argentina, Bolivia are also hotspots for gallbladder cancer. So this is something quite close to my heart. Just this month, we have seen publication from an observational study of 1,500 patients with metastatic disease. This is gallbladder cancer. 80% of patients presented with metastatic disease. You can see here a small minority underwent surgical exploration, 116 out of 1,500 patients. And 6% of patients underwent definitive surgery, achieving a 1-year survival of close to 90%. But I think the reality is that because most patients present with metastatic disease, half of the patients were planned for palliative chemotherapy, and only 38% of patients received more than one cycle of treatment. So we know that we're dealing with a really adverse prognosis, a really challenging situation. The median overall survival of patients receiving treatment was 5 months. So this is really an area of unmet need and something we need to really improve on globally. So the question is, what evidence do we need? Well, let's just quickly focus on what evidence is available. And I looked up evidence, and it's the available body of facts, not just something that we choose to focus on, but it's taking into account the totality of the body of facts that we have available. And very often, traditionally, we think of this as the classical drug development academic pathway, looking for safety and recommended dose in phase 1 studies, getting an initial feedback of efficacy in a phase 2 study, particularly in the indication that we're interested in. And most of the time, we focus our decision making on the magnitude of benefit seen in phase 3 studies. Of course, there are also post-marketing surveillance studies, phase 4 studies, which give additional safety information in a more real-world setting, and of course, meta-analyses that combine phase 3 studies have greater robustness. So from left to right, we can see increasing robustness of the data that we have available. But that is not the total available body of facts. We need to include also personal experience as clinicians start using new treatments. We can look at our own cases and look at auditing the outcomes that we're seeing from those cases. We know that there are occasional published case reports, and then we have series, prospective and retrospective series, which may be single institution, multi-center, and international. And increasingly now, we are thinking about using real-world data and real-world evidence. So it's really putting all of this together that helps us to make decisions on the best use of our therapies. I think it's an important point to start with our phase 3 trials. So as a takeoff point, I'm just going to show these data, which are known to all of you. These are the original survival curves from the Topaz-1 study and the Keynote 966 study looking at durvalumab and pembrolizumab respectively in well-designed prospective phase 3 placebo-controlled clinical trials. And you'll know that the original durvalumab study showed a hazard ratio of 0.8, so a 20% reduction of risk of death at any time. And in the Keynote 966, this was a 17% reduction of risk of death with a hazard ratio of 0.83. And one of the things that you can see is that these curves appear to diverge over time. And that was more evident with the updated survival data, which have been presented and published. On the right, for pembrolizumab, this was presented in 2024. And on the left for durvalumab, it was my pleasure to present these data at the EASL Liver Cancer Summit last month. And these are now 4-year survival data. Now, remember, when we did the ABCO2 study, the likelihood of patients getting to 3 years was only 3%. And we're now seeing survivals at 2, 3, and 4 years. And if you look at the difference between these two at 24 months, the difference between, or the ratio of 23 with durvalumab versus 13.7 with chemotherapy only, the overall survival rate ratio is 1.69. And this, in fact, continues to separate. So at 3 years, it's 1.97. At 4 years, it's 2.74. And we're now seeing around 12% of patients who are alive at 4 years with a combination of immunotherapy and chemotherapy. Of course, one of the challenges is knowing who those patients are at baseline, who are the patients who are most likely to benefit from treatment. Because as you can see in the very first, particularly the 6 months, there is really very little separation of the curve. So this is something that is seen as a delayed effect. So what did Topaz and Keynote tell us, and what did they not tell us? Let's start with what they did tell us. The addition of immunotherapy improves survival. I think it's important to acknowledge that the magnitude of that benefit is modest, and the effect is mainly seen after the median. Additional toxicity, and I won't go into that, is manageable. We are, of course, dealing with a biomarker unselected population. And what we found from Topaz is that maintenance immunotherapy allowed chemotherapy to be stopped, which is often very welcome by patients. But what did it not tell us? It didn't tell us about the benefit in anatomical subgroups. I think by necessity, there is a history of the randomized trials in biliary tract cancer, right back to ABCO2, of including different cohorts of patients, cholangiocarcinoma, gallbladder cancer, sometimes also ampullary cancer. And that's largely driven by the rarity of the disease and the need to have enough patients to have statistically powered studies. So we're now dealing with anatomical subgroups, and we're trying to understand what the benefit is for those. It did not tell us what the efficacy is in combination with the different chemotherapy spine to cisplatin and gemcitabine. Now, we do know so far that PD-L1 isn't a reliable biomarker to select patients. And also in real life, we have patients who have a different profile. They may have a performance status of 2. They may have liver function tests, which are not within the very tight ranges that you expect for a clinical trial. And what is the benefit of immunotherapy in a different line of treatment, either second line or increasingly in the neoadjuvant or adjuvant setting? But let's just try and focus a little bit on the gallbladder cancer subpopulation. In Topaz-1, this constituted 25% of patients, so there were 171 patients with gallbladder cancer. You can see here in the forest plot, that is a very relatively small dot signifying the size of the patient group was very small, with rather wide 95% confidence intervals, which were included in the original 95% confidence intervals of all patients. So again, it's difficult to have statistical power for this, but it's within the range that is expected for the whole group. And a similar thing is seen with pembrolizumab in the Keynote 966 study. The 95% confidence interval of this 22% of patients fell within the overall 95% range of the overall study. So, of course, a huge caveat for this is like the other subgroups, the studies were not statistically powered for such subgroup analysis. So we can only take this as exploratory data. Since then, of the last couple of years, there have been some real-world data publications, and I've taken 4 of those here from Germany, Japan, Turkey, and then a global one led by a group in Italy, Margherita Rimini and colleagues, which was data including Europe, US, and Asia. On the left, I've put the TOPAZ-1 reference study. So in the arm that receives cisplatin gemcitabine and durvalumab, there were 341 patients. Just to remind you, the median PFS was 7.2 months and the median overall survival, 12.8 months. And what these real-world data, some of them are small. The last one, the global one, is a much larger study. But what they're showing is that the median progression-free survival is very much comparable with what was seen in the pivotal study. So it's giving approximately the same magnitude of benefit in terms of disease control, but that also translated into a median overall survival, which on the whole is similar, sometimes a little bit longer, than that seen in the pivotal TOPAZ-1 study. If we just narrow down into the gallbladder cancer group, just to remind you, there were 85 patients with gallbladder cancer in the TOPAZ study. And now we're dealing with small numbers, 18 patients, 13, and 11 patients. So that inevitably has some caveats around the sample size, a much bigger sample size in the global study. And what you're seeing here, the reported PFS, is in the region, but probably a bit shorter than the PFS that we're seeing across all patients. So we're seeing that both in the PFS, but also the median overall survival here, you can see, is shorter than what is being seen in the real-world studies of the wider population. And what all of these 3 smaller studies showed, and I've taken this from the individual papers, is that gallbladder cancer independently has a worse overall survival in the German study. Gallbladder cancer significantly worse OS in the Japanese study. In the Turkish study, is a combination of extrahepatic cholangiocarcinoma and gallbladder cancer having an inferior overall survival. You won't see this in detail here, so I'll just blow it up. This was looking at the hazard ratio of this comparison versus the other. So it wasn't immunotherapy versus no immunotherapy. It was within immunotherapy. In fact, the largest study by Rimini and colleagues showed that, in fact, the hazard ratio of patients with gallbladder cancer was very similar to intrahepatic cholangiocarcinoma. So that was a little way away from what we've been seeing with the previous studies, where gallbladder cancer has an inferior outcome. So what are these studies telling us when we take them in their totality? First of all, they're telling us that the activity of durvalumab across all biliary tract cancer patients is comparable to that seen in the TOPAZ-1 study. We are seeing that patients with gallbladder cancer have inferior outcomes. And I think what this is telling us is that we're dealing with a different biology. And what we should be doing going forward is having studies that focus specifically on gallbladder cancer as a discrete entity. And India has a very strong proven track record of having studies that are specifically focused on gallbladder cancer. And I think that's a direction that we should also be moving in the West. So there is one study that was specifically focused on gallbladder cancer and undertaking propensity score matching. They were accessing the Trinex global network, from which they identified 2,500 patients with gallbladder cancer with advanced disease, of which you can see here 130 received cisgem durvalumab and 201 received cisplatin gemcitabine. And what they did is they undertook propensity score matching to make these as comparable as possible, within which they had 111 patients per group. And what they were able to show here in the Kaplan-Meier is that there is a definite separation of the curves with a median overall survival of 13.1 months in patients receiving immunotherapy versus 8.5 months in patients receiving chemotherapy only. Another question is, does it matter whether it's pembrolizumab or durvalumab? And there will never be a head-to-head comparison trial of these two immunotherapy regimens. It's not really the academic question that we really want answering within a prospective randomized clinical trial. But in order to address the question, there was a reconstruction of patient-level data mimicking a head-to-head comparative analysis published in 2024. And what they were able to do is using the patient level data is to reconstruct the Kaplan-Meier curves on the left for survival. And you can see here that these are completely interposable. And on the right for progression-free survival, so some differences here, but in fact the hazard ratio was not statistically significantly different. So I think what this analysis is telling us is that what we're seeing is a class effect. And we're now getting many, many PD-1, PD-L1 inhibitors. And I think we can take the lesson from here to think that if we can access a different PD-1, PD-L1 inhibitor, then it's likely to have the same class effect. There's much more data to come. So there are combinations with other types of chemotherapy, combinations with targeted therapies, combination with anti-angiogenic therapies, which are now coming through, as well as new agents which are particularly targeting the microenvironment modeling. And this, of course, is the addition of new agents, and this largely fills this box here, where we're also combining it with other modalities of therapy, like radiation, tumor ablation, for example. But of course, there is a great interest in harnessing the immune response by using bispecific antibodies, agonistic checkpoint antibodies, adoptive T-cell therapy, and vaccines. So I think we can look forward in the next few years to a lot more data on understanding how we can best harness the immune response. A couple of studies to highlight, and I know that these are recruiting in India. So one is the tourmaline study. This is including a broader set of patients. So it's including patients with ampulla ovata cancer, including patients with performance status 2. And it's looking at the combination of durvalumab with other chemotherapy regimens. So either gemcitabine monotherapy, cisplatin gemcitabine, but in a PS2 population, using other platinums like oxaliplatin, carboplatin, and then using S1, which we know is used much more widely in Japan. And whilst the study is looking at efficacy overall and progression-free survival, these are secondary endpoints. The main endpoint of this study is looking at safety adverse events within the first 6 months. The other study that we're really looking forward to the results of is the Artemide biliary 1 study, which is now using immunotherapy in the adjuvant setting. And so this is using a bispecific antibody, rilvegostomig, which simultaneously binds to and inhibits PD-1 and TIGIT. And this is a very pragmatic study in that it's randomizing patients to adjuvant chemotherapy with or without rilvegostomig or placebo. But the chemotherapy is investigator's choice. So it allows a bit of flexibility for this to change if we get new evidence of a new standard of care. And one thing that's very important is the safety of using these treatments. And I know that one concern that many of us had when these studies were being designed was what the safety would be like in a hepatitis population. We know that chronic hepatitis B infection is a risk factor for biliary tract cancer and could potentially impact the effectiveness of immunotherapy. And exploratory analysis, this is now in the Keynote 966 study, showed that there was a low incidence of hepatitis B reactivation and no cases of hepatitis B associated hepatitis. And it's reassuring to see that patients who had hepatitis B positive or negative status derived the same magnitude of benefit. And it's important that hepatitis was handled on study management as shown in the box on the left. This is obviously important. We have very different exposure to hepatitis B in different parts of the world. India is not the highest, but it's clearly something that's going to be relevant in managing patients with advanced biliary tract cancer. We also need to think about response modifiers that we might need to factor going forward. So we know that the immune response, so innate immune response, may differ by gender. It changes as we get older. It may differ with malnutrition and some of these other factors, stress, obesity. And obviously, the microbiome is a hot area of investigation at the moment. And this is relevant to the microbiome within the biliary tract, bile microbiota, but also gut microbiota, because we know that through the enterohepatic circulation, there is a close relationship between what is going on in the bowel and what is going on in the liver. Um, Colleagues in the UK have just completed the ABC-12 study, which was an observational study looking at patients receiving durvalumab, cisplatin, and gemcitabine, and collecting saliva as well as stool samples. That study has now completed recruitment. We're waiting for data to mature, and we will see some of that presented in the next year or so. So with that in mind, I want to close with take-home messages. How much evidence is enough to treat? We have phase 3 studies. We have real-world data. We know from the combination of those, immunotherapy improves survival, but the magnitude is modest. There is an increasing number of long-term survivors. It's safe, including patients with hepatitis B, provided that's managed carefully. And real-world data confirms the magnitude of benefit. And gallbladder cancer, we now see, has a very different biology, which is more aggressive, and we need separate studies. There is still a lot to learn, much more data that we need. What's the appropriate combination, sequencing of therapies, response modifiers, predictive biomarkers, how do we harness the microbiome, and the whole next generation of immune therapies. And with that, I will close and invite you to attend our conference, May 1st to 3rd. You can attend either in person or online as we celebrate our 20th anniversary. Thank you so much.
Thank you.
Everyone.
Thank you for that great presentation. I think, so we have some questions in the chat. I'd like to quickly begin or address a few of them. One question that came twice, I think, I got a forward as well as Dr. Rakesh Chopra here. Sir has joined in and he had put in a couple of questions as well. And one of the questions asked for what are the ways, any molecular markers, signatures for early diagnosis or screening of gallbladder cancer and cholangiocarcinoma. And I think one such question came to me as well, where they're saying, since a lot of these cancers are diagnosed at an advanced stage, 50% you mentioned in your talk, where the patients were only eligible for palliative treatment, and 38%, I guess, got above one cycle. Only 38% got above one cycle. So the question regarding screening, anything that is happening regarding screening, or to understand why epidemiologically it is at such a high percentage in, as you mentioned, Peru or in certain parts of India, that's the...
Yeah, that's an excellent question. And whilst we celebrate some of the advances that we're making in advanced disease, I think where we're really going to change the dial in terms of overall survival is going to be in screening, prevention, early diagnosis, because that hopefully will then allow more patients to undergo curative therapy if they have got a diagnosis. So improving our, surgery and adjuvant therapies, that's really where we're going to shift the dial. We don't, at the moment, have any screening test that we can use for biliary tract cancer widely. There are many groups that are working on this. And the reality is that in an unselected population where this is so rare, it's going to be very difficult to find something. So initial endeavors are focusing on at-risk populations. So we know, for example, for cholangiocarcinoma, PSC, primary sclerosing cholangitis, is a population where there is a 20% lifetime risk of developing cholangiocarcinoma. So in that at-risk population is where a lot of the work is being done. And whether it's extracellular vesicles or a protein or a ctDNA or some trace of early cancer, if it can be found in that enriched patient subgroup, we can then start thinking whether this is also applicable to a wider population. But currently, to date, there is no screening test. The one thing that people often ask about is CA19-9. CA19-9 is a protein that is very capricious, so it can be elevated in the absence of malignancy. In the presence of malignancy, it might be negative because 8 to 10% of people can't produce the protein. It's linked to your blood group, and so some people can't make it. And so it's not really a reliable biomarker to use for screening.
So essentially, the message is there's a lot of work happening, nothing ready for prime time recommendation as a commercial test, but the field is truly moving. And I've personally actually been a liquid biopsy person, very involved in my work in early diagnostics and MCED, the multi-cancer early detection. And I can tell you that this is what we are seeing is just the tip of the iceberg, that there is a lot happening in that space, but truly nothing ready for prime time utilization. And especially when it concerns early diagnostics, I think it is both the genomics or the biomarker field that needs to come up, and also AI in terms of risk identification. I think we are still falling short significantly for that to become a standard of care. One last question, in interest of time. There's a question regarding FGFR and gallbladder or cholangio. And so I guess it suffices to ask whether, biomarker, you showed a slide, actually a couple of slides on how biomarker integration into designing clinical trials for gallbladder cancer is already happening. When we run studies like Topaz or the keynote study that you just showed, why isn't biomarker integration done for these trials? Because even then it was known that cholangiocarcinoma is the new lung cancer, where so many pathways have already been recognized. Why does it happen like this? I guess this question is regarding the drug development.
Okay. Yes, it's a good question. I think at the time that the studies were being designed, biomarker subgroups within cholangiocarcinoma were still relatively new. We certainly didn't know about their prognostic value, which is where you want to start integrating it into study design to make sure that you've got balance across the groups and you're not driven with a survival advantage due to a favorable biomarker. We have previously presented the results of the biomarker subgroups within Topaz-1, and it appears that all of the subgroups have a similar magnitude of benefit. But just kind of quickly taking one step back, I know the question started with FGFR, but we know that within biliary tract cancer, the different anatomical entities do tend to enrich for different biomarkers. So FGFR, IDH1, predominantly intrahepatic cholangiocarcinoma, but we know that HER2, for example, is much more likely with extrahepatic cholangiocarcinoma and gallbladder cancer. So going forward, it may be that if we are designing specific studies for gallbladder cancer, we might need to think about, stratifying for HER2 status, largely because patients, will be receiving one, maybe more HER2 targeted therapy, and that might skew your survival. So I think it's a case of designing our studies with what we think is most likely to affect survival as a stratification factor.
Amazing. I think not just cholangio, not just gallbladder, but also subparts, and things are becoming much more nuanced and really a space to look out for. So that was a great talk, and thank you for answering some of our questions. More will come through. Request you to just be around to take some of those questions. And moving over to our next speaker, really, Dr. Valle, thank you. Really, really great for that insightful talk. After that, we move to Dr. Eugene Coy, who is a radiation oncologist and professor in radiation oncology at MD Anderson Cancer Center in Houston, Texas. And he specializes in gastrointestinal cancers, in particular in pancreatic and hepatobiliary malignancies. Dr. Quay has been practicing what I call precision radiation oncology, and a lot of his work is in biomarker-directed therapy allocation and implication to nuances of biomarker identification. We are here today to hear from him regarding radiation therapy in cholangiocarcinoma, from marginal role to strategic tool. Thank you so much for joining us, Dr. Quay, and the stage is yours.
Thank you so much. It's a real pleasure to be here. I appreciate everybody taking the time this evening and this morning, wherever you are in the world, to join us. So a lot of my work is inspired by astronomy. So this is a picture of a supermassive black hole, which I'll tie into the talk in just a little bit. So these are my disclosures, none of which are relevant for today's talk. I'd like to start off with just a case and emphasize the importance of achieving local control, meaning getting control of the primary tumor in the liver, especially for cholangiocarcinoma. This happens to be a patient with intrahepatic cholangiocarcinoma. This was before the TOPAZ and Keynote studies were published. This person received gemcitabine cisplatin for 6 months and then unfortunately eventually progressed, as shown here on the right, after several months of the chemo, and eventually died of liver failure. This is the proximate cause of death, the most common early cause of death for many, many of these patients that we've seen at MD Anderson and probably abroad, because these tumors can be recalcitrant to the systemic therapies alone. And it emphasizes a role that a local therapy such as radiation, Y90, or other types of liver-directed treatments may play. And indeed, whenever we looked at our retrospective examples of patients who had intrahepatic cholangiocarcinoma over about 20 years' time, we observed that 83% of these patients died of biliary and or liver vascular problems. The primary tumor would grow to such an extent that it would actually block the bile ducts, leading to biliary obstruction, which can lead to cholangitis and sepsis of the patients, which is deadly, and or have one of the major blood vessels of the liver, the hepatic artery, the portal vein, or even the outlet of the liver vascular system, the hepatic veins, get closed or occluded by these tumors, leading to a shutdown of the organ and death of the patient. So again, this emphasizes the need to get control of these tumors, whether by systemic therapy alone, but largely also perhaps with local therapies like radiation. So improving local control is something that we would expect to significantly prolong the survival and quality of life of these patients, because once they get these biliary or vascular problems, many downstream problems arise, including the need for percutaneous drains, stenting, or other types of interventions to help with ascites, for example. So I'm going to break this talk down into two different disease sites, extrahepatic cholangiocarcinoma and then intrahepatic cholangiocarcinoma. The first, we'll talk about unresectable extrahepatic cholangiocarcinoma, for which a large randomized trial with the ABC trial group, ABC07, was recently published or presented at ASCO 24. We're awaiting the full publication. But what this looked at was the randomization in a 2-to-1 fashion of patients receiving standard of care cisgem, which is the standard of care shown at the top, versus cisgem plus radiation, which could have been in 5 or 15 fractions using an SBRT, stereotactic body radiation technique. The primary endpoint here was progression-free survival, but they also had key secondary endpoints of local control as well as overall survival. Here's the overall survival results that they presented at ASCO. And unfortunately, there was no difference between the two arms here. And what this also emphasizes is that they screened 432 patients, but were able to enroll 83, and 69 of those patients were randomized. It's also important to note that 84% of these patients had extrahepatic cholangiocarcinoma in this study, perihilar disease. So this didn't really encompass the other biliary tract diseases such as intrahepatic cholangio or gallbladder cancers. This is largely, 84% perihilar extrahepatic cholangio. Other key endpoints to note here are that the 12-month survival rates for the patients who got the radiation were 77% versus 66, and that 24% numerically, the number was 42% versus 31.8%. So not statistically significant, but some suggestion that there might be some separation with a limited number of patients. Here's the progression-free survival curves. You can also see that there's no difference here either. Interestingly, whenever they break this down into local control, they did observe a local control numerical difference for the patients who got radiation. Also notable is that fewer patients in the radiation cohort died of liver failure. So again, kind of speaking to that importance of local control. However, in this particular study, that did not translate into progression-free survival benefit or overall survival benefit. So we're awaiting the full results of this in publication form, but this is one of the first studies to look at the role of radiation, particularly for extrahepatic cholangiocarcinoma. So now, what about intrahepatic cholangiocarcinoma? What are the results there? There are a number of opportunities, and as I kind of alluded to, supermassive tumors, what we call very large tumors here. Again, kind of going back to that first slide with the supermassive black hole, we can treat tumors in the liver that are very, very large, over 10 centimeters, sometimes upwards of 20 centimeters in greatest dimension. Again, ABC07 was largely perihilar, and there have been no randomized trials for intrahepatic cholangio, or at least where intrahepatic cholangio was the majority of the patients. Many of these studies, especially with radiation and ABC07, were extrahepatic cholangiocarcinoma outside the liver. So with intrahepatic cholangio, the evidence is largely with single-arm prospective phase 2 studies, single institution or retrospective reviews, or large databases that have limited clinical data on a per patient basis. There's a lot of heterogeneity in these studies. We've talked about biomarkers in the previous talk by Dr. Vale, as well as in the discussion. There's a lot of need for this because we know that intrahepatic cholangio is target rich as far as drugs and other biomarkers that portend different prognoses. So these are some things that we need to keep in mind as we interpret these results. So first, what was the MD Anderson experience? We looked back on about 15 to 20 years of experience of 79 patients who received external beam radiation, for their intrahepatic cholangiocarcinoma. And you can see the median size here was 7.9 centimeters, so fairly large. And we followed these patients for quite a long time, median of 33 months. And in this study, we published a median overall survival of 30 months with a 3-year overall survival rate of 44%. These are quite comparable to some surgical series, in fact. Not quite as good, but still very comparable and the best at the time as far as intrahepatic cholangiocarcinoma outcomes were reported. And the single most important prognostic factor in this particular study was the dose of radiation that we gave. Over the years, there was a technology drift where in 2007, we started instituting the types of technologies that would allow us to safely escalate the radiation dose to higher and higher doses, sometimes up to 100 gray and 25 fractions. Our more typical doses these days are 60 to 67.5 gray in 15 fractions, a hypofractionated regime that is associated with local control, better local control than more standard doses of radiation, such as 50.4 gray in 28 fractions, which is kind of the traditional dose that you give to the upper abdomen, traditionally for liver and pancreas tumors. You can see the associations by the biological effective dose, BED. This is a way to standardize the dose of radiation based on the number of fractions as well as the dose per fraction. And you can see that once you get above a BED of 80.5, the 3-year overall survival rates and local control rates are significantly better compared to lower doses of radiation. We did a prospective phase 2 study with protons using those 15 fraction regimens, 58.05, about 60 gray to 67.5 gray in 15 fractions. And the dose of the radiation was dependent on where the primary tumor bulk was. Was it central? They would get the lower doses to allow for tolerance of the common bile duct. Versus more peripheral, they would get the higher doses of 67.5 gray. And this did include both patients with intrahepatic cholangiocarcinoma, ICC here, or hepatocellular carcinoma. And you can see the survival rates in both groups. This was actually quite striking because by themselves, with this proton radiation regimen, the survival rates at 2 years were the best that were reported up to that date. We've now looked at a multi-institutional retrospective data set by combining our data from MD Anderson with others from around the US, Massachusetts General, Ohio State, Mount Sinai, Stanford, UCLA, Utah, and University of Washington. Here, similar to our MD Anderson experience, our median overall survival, was over 30 months, 32 months in this particular study, with a median progression-free survival of 19 months. So the publication here is pending submission, but we're very excited by these results because they really emphasize the ability to export these higher doses of radiation safely to patients with intrahepatic cholangiocarcinoma. So I'd like to take a step back and just kind of ask, why are we seeing these differences in outcome between patients who receive radiation for intrahepatic cholangio versus extrahepatic cholangio? The ABC07 study was just the only prospective study that I emphasized for today's talk, but there have been a number of retrospective studies also for extrahepatic cholangio, indicating that the dose response that we see with extrahepatic cholangio doesn't translate to better survival outcomes as we would see or expect with intrahepatic cholangiocarcinoma at this point. And there could be a number of reasons. Radiation dosing for extrahepatic cholangio, ECCA, is limited because there are a number of surrounding organs by that common bile duct and perihilar area, including the stomach, the intestines, especially the duodenum. Whereas with intrahepatic cholangio, that's not often the case. You do sometimes have those structures nearby, but you're able to get central liver control because you can escalate that dose of radiation safely to the majority of the tumor. And so that's what we've observed in our retrospective as well as prospective studies for intrahepatic cholangiocarcinoma. We can get the dose higher and cover more of that tumor volume with that high dose more effectively without compromising our dose or compromising our toxicities due to external beam radiation exposure to other luminal structures like the stomach. Also, whenever you look at extrahepatic cholangiocarcinoma and the mutation landscape, these more often have KRAS and or P53 mutations, which are associated with radioresistance. So it is really kind of a different disease entity in my mind, as well as what Dr. Vale recently said in his talk. This is a more of a desert of targetable mutations. We do not see as often these IDH1 mutations or FGFR aberrations as we see in intrahepatic cholangio, and those also carry prognostic implications with them as well. And then, of course, there's also a wider array of targeted therapies now for intrahepatic than extrahepatic cholangio, and that could also lead to some of the observed differences because some of these patients do go on to systemic therapies that target specific mutations. So with all of that information, how does this change patterns of care? We haven't seen randomized trials for intrahepatic cholangio once again. Some of those are ongoing, and I'll emphasize that in just a moment. But we did look at the patterns of care within the US using the National Cancer Database, NCDB. Between 2004 and 2018, there were 37,000 cases that met this diagnosis code of C22.1. And so we eventually went through this and categorized them according to what type of treatment that those patients received. Some of them did not receive any. Some got chemo without liver-directed radiation. Some received liver radiation without any chemo, and it's a combination thereof, along with other local therapies. We eventually wanted to figure out what is the change in the practice patterns of the use of liver-directed radiation for this particular study. And here our study population eventually came down to 809 patients who received conventional radiation during this time period of 2004 to 2018 versus higher doses of radiation, again, using this BED or biologically effective dose calculation based on the number of fractions and the dose per fraction. And for that, we had 303 patients, 27% of the entire population here. And these were the key results. During the study period, you can see that the proportion of patients receiving liver-directed radiation basically stayed flat the entire time. It's around 12 to 15% in this study period. It really did not change to any significant degree over the course of time. Despite the publications that we were showing during this time period, between 2010 and 2018, to show that higher doses of radiation were leading to prolonged survival for intrahepatic cholangio. However, whenever you look at the dose per fraction and this BED, what we call ablative radiation therapy, ART, you can see that the utilization of ART did significantly increase over time, again, because of the adoption of new technologies. And we think because of some of the publications that we were able to put out there during this time period. So you can see regionally across the US how these things were changed. So how did the use of liver-directed radiation show? This is shown in the blue. And essentially, this area of the US did increase its utilization of radiation. Texas did also increase its utilization just slightly, largely because MD Anderson is here. You can see the use of ablative radiation doses also, and that also seemed to trend similarly with the use of liver-directed radiation during the time period. So these are very interesting results, and it's notable that despite seeing some promising results with external beam radiation for cholangio, this bar did not really change for overall use. Further, whenever we looked at the outcomes for these patients in terms of overall survival, based on either conventional radiation or ablative radiation versus all the other combinations thereof, those patients who received ablative radiation did seem to do better as far as their overall survival, and then also whenever in combination with chemotherapy during this time period. So how do we increase this utilization of radiation from marginal to the strategic role that we think it should play in selected patients? And especially not just in Houston, MD Anderson, and some of the parts of the US, but really more widely across the globe. We really think that this can help patients because this utilization rate being so low, less than 15%, we think it should be higher. And again, for selected patients. So I think the answer is that we need randomized trials. And to that effect, we're running one for patients with oligometastatic or locally advanced disease for intrahepatic cholangio. And this is largely based on a retrospective study that we published in Liver Cancer in 2023, where we looked at outcomes of patients who received liver-directed radiation while having extrahepatic metastases from intrahepatic cholangio and compared their outcomes to patients who just received systemic therapy alone during that time period. And the key result here was that these patients who received liver-directed radiation had better overall survival, and they were less likely to die of liver failure. Again, going back to that first case presentation, where local control, we think, matters, even whenever you have, facing this situation of extrahepatic metastases, disease outside the liver. Getting control of that central tumor and that burden of disease in the liver does make a difference, even for the more advanced disease presentations. So to that effect of trying to achieve randomized trial evidence, to demonstrate an overall survival benefit, we're conducting this study. We call it Hyperion CCA, which is a randomized trial of systemic therapy plus or minus liver-directed radiation for patients with locally advanced and or oligometastatic intrahepatic cholangiocarcinoma. They're randomized 2-to-1 to receive radiation versus standard of care Gemcis Durva. And we're funded by AstraZeneca, Varian, as well as Rising Tide. And our total N here is 126 to be enrolled. Very notably, we're also partnering with our friends in India, AIG, as well as Tata Memorial, to conduct sister studies for this so that we can combine the data together and demonstrate exportability of the approach. So really, how do we achieve the results? And ultimately, the details matter. So in these last few slides, what I want to emphasize is that you can't just escalate the radiation dose without paying attention to the anatomy and the setup of the patients. This is a spatially localized, as the introduction said, this is precision radiotherapy. We have to be very meticulous about where the dose goes and pay attention to how the patient is set up. And so to that effect, we manage the motion of this by having the patient either hold their breath or only gate the radiation delivery while the tumor is in a certain location. We also dose this differentially based on where the tumor is relative to the bowel, the stomach, and have dose fall off so that the dose touching the stomach or other intestinal structures is safe. And then, of course, we use conformal ways of delivering the radiation with either IMRT or protons, as shown here. And our image guidance on a daily basis ensures that what we planned originally whenever we set up the patient for the radiation is what we're actually delivering on a daily basis by actually taking a picture, a CT scan in the treatment position before we turn on the radiation beam. And we can look at the daily scan on the left versus the reference, which is what we used to plan the radiation originally, to make sure that everything is consistent internally and we're delivering exactly what we want to do and not overdosing any of the other structures. So I'm proud to say that we've been sharing this, a technique of radiation across the globe, including, during the Asia Pacific Cholangiocarcinoma Conference in 2023 at Tata Memorial, and also in Korea more recently. So we're very happy to share this with anybody who's interested. We definitely want to make sure that we disseminate these in a very thoughtful and judicious way so that we can help patients all over. So just to summarize, we're trying to build the evidence to use radiation as a strategic tool for cholangiocarcinoma. The results with extrahepatic cholangio are modest, but they do suggest a local control benefit and a decrease in the risk of liver death due to the extrahepatic cholangio. Similarly, whenever we do this for unresectable intrahepatic cholangiocarcinoma, we are seeing patients who have long-term survival, which is very promising, but we do need randomized trials. We want to reduce the risk of liver failure by giving these higher doses of radiation, and we need to do so thoughtfully using the technologies that we have at our disposal. So I want to take the last few moments to just thank all of the people who have made this possible. Dr. Milind Javle particularly, he's been central to all of these investigations that I've presented today, but we have so many friends in India as well as across the globe that have contributed to this. And then, of course, the Cholangiocarcinoma Foundation, ICRN, and Jarurat Care, who have invited us to do this today. Thank you very much.
Thank you, Dr. Coy. This is a great lecture, and the precision radiation oncology was very, very obvious. We have some questions. I think this is really, I would say, pioneering work, because you're trying to bring in radiation in an area where it is minimally existent, and also trying to look at specialized ways to perform this radiation treatment. One of the very obvious facts of the presentation was in the ABC-07, the study did not reflect significant survival advantage for the patients that were assigned. And just taking a drift from the questions that were asked in the chat box, what would you change in the way the ABC-07 study was designed? If you had to design it now, how would you think of it at this current time? Would you do it
Yes,
differently? Is there some realization from that study that you would like to bring to the fore?
right. I think that it'll be very interesting to see how Dr. Hawkins, who's the overall PI for that study, with the radiation, what was the dose coverage of the tumor? In our studies for intrahepatic cholangiocarcinoma, the amount of tumor covered by at least 90% of the prescription dose. So if you're giving 60 gray in 15 fractions, you want at least 90% of that 60 gray to be covering, the tumor, to a good extent. We're not sure what that looks like for ABC07 as yet. We're awaiting the results and their analysis of that. So I think that will be very informative to help us understand just how much tumor coverage with the high dose of radiation were they able to achieve. So that's unknown right now, and until we get those details, it's kind of hard to answer the question fully because we think that the dose matters.
Yeah.
And once again, with 84% of those patients having extrahepatic cholangiocarcinoma, we know for sure that there's going to be under coverage of the tumor volume by the high dose radiation field because of the limitations that we have with the bowel structures. If you overdose those with this radiation, you're going to cause a bowel perforation, ulcers that bleed, so that could be deadly in and of itself. And so you have to be very careful with how you administer the radiation for extrahepatic cholangio. And I think that that's something that we just don't know quite yet.
Great. My last question, and again, this is from Dr. Ashu Abhishek, who is himself a leading radiation oncologist at Apollo Proton Center in Chennai. He's put in some questions where he's asking if the modern radiation techniques, you mentioned proton, ART ablation, ablative therapy. So of course, bringing in radiation into this area, but with a difference. So when you talk about side effects and large tumors, you showed some of the last slides were with very large tumors. As we look at radiation coming into these areas, my concern as a medical oncologist, when I refer to my radiation oncology colleagues or vice versa, would be toxicity and which modality to utilize, which center to refer my patient to. Because, if you refer a patient to a certain center and that center does not have proton, that patient will end up getting a regular IMRT. Mostly the patients get retained at the centers where you refer. So what would be your message with the type of radiation in such situations? This is very nuanced.
Oh, absolutely. Whenever I give these types of lectures to our residents, as well as, at these conferences, in a more detailed setting, it's really important to risk stratify the patients, especially whenever they have very large tumors and perhaps underlying cirrhosis or underlying liver dysfunction. So we know that an excellent predictor of toxicity to the liver prior to radiation is the Child-Pugh score. This is largely developed for cirrhosis, but it can be applied even outside of patients who do not have cirrhosis. So those who have higher Child-Pugh scores are more likely to develop radiation-induced liver disease. We know that based on many, many studies now. So that's a good way to risk stratify your patients up front. If they have a normal Child-Pugh score, A5, they can receive these high doses regardless of the size of the tumor as long as you meet your liver dose constraints. With 15 fraction regimen, for example, we would try to keep the average dose to the liver minus the tumor volume to 24 gray or less. So if you're able to achieve that, you can expect that you're not going to cause radiation-induced liver disease. It's a safe dose of radiation to the liver. The liver is a very hardy organ otherwise, as long as you keep that average dose of radiation below 24 gray. And you can extrapolate that to other regimens, 10 fractions, 28 fractions, etc. So we teach those dose constraints and and really harp on those because that is the key to determine toxicity, along with all the other bowel and stomach constraints. So the key is that you have the necessary technologies, and that could be IMRT or protons, but also image guidance and motion management. As long as you have those three key technologies at the center and meet the dose constraints, the radiation should be safe in well-selected patients.
Great, great talk and great inputs. Thank you so much,
My
Dr. Coy.
pleasure.
I
Thank you.
request you to just stay behind for
Absolutely.
some time. Actually, there's a little small change in the schedule that I request. I think Dr. Himthani has just joined. I request you to stay on. I actually would like to welcome Dr. Sailesh Talati. Dr. Talati has a case that he would like to discuss in this forum. And Sir is a leading senior oncologist from Ahmedabad and has been a pioneering medical oncologist from this part of the world. And we've all learned so much from him. Sir, thank you so much for joining us today and for sharing this case.
Thank you, Sevanti. Thank you, Jarurat Foundation, for giving this opportunity. We have heard two excellent lectures from dignitaries, Dr. Vele and Dr. Koya. And here is a related case I would like to represent and take opinion of the experts who are around. Here is a 50-year-old female with no major comorbidity. In May 24, she presented with obstetric jaundice due to hilar biliary stricture and underwent multiple procedures, CRCP, PTBD, CBD stenting, and no definitive diagnosis was confirmed. Also was treated once for IgG4 related disease with steroid. Up until August 25, that's almost 1 year, when blood cytology and biopsy of the hilar stricture confirmed well-differentiated adenocarcinoma. Thinking that it was a local regional disease on the radiology workup, where the FAP PET scan showed soft tissue thickening around CBD, CHD, and LHD, encasing LHA and LPA. They decided to go for a surgical opinion, went to a tertiary center in USA, where again CT scan showed pancreas angiogram, showed triple phase, showed hilar mass, which was stable as compared to the last FAPI, and maybe slight decrease in the size. So, sorry, to go next. Just a second. Sima. Sorry, just she underwent. She went to US for a surgical opinion where diagnostic laparoscopy, cholecystectomy, and lymphadenectomy was done. There was no metastatic disease then, and the mass was found within the hepatoduodenal ligament extending from left to right, involving the right hepatic hilum. The tumor involved neural and lymphatic tissue encased and hepatic artery posterior to the bile duct. Due to inability to separate the artery from the tumor, the lesion was deemed undissectable and resection was aborted. On histology, no nodal metastasis was found. Liver biopsy of segment 4B also positive for adenocarcinoma, and diagnosis was confirmed as hilar cholangiocarcinoma. Histology finding there were no biomarkers, MSI stable, HER2 negative, and there was some FGFR2 mutation, a loss of it, but no actionable one in FGFR. Even the liquid biopsy did not yield anything as a druggable mutation. So they returned to India and we started as a locally advanced inoperable hilar cholangiocarcinoma with standard chemotherapy, cisgem, durva. received 3 cycles of chemo immuno, and the FAPI in December showed a partial response, portohepatic lesion shrank, and there was persistent CBD involvement and possible small cholangitis. So we went ahead and gave another 3 cycles of same cisgem durva. Around the 6th cycle completion, she had some stent-related infection blockade where ERCP and change of stent was done, and radiofrequency ablation was done for the intraluminal disease. Recently, we have, after completion of 6 cycles, started around maintenance durvalumab 3 weekly. The last FAPI PET scan showed stable disease as compared to the last imaging that was done in December, with stable disease at porta hepatis region, involvement of the proximal CBD confluence of the right and left hepatic duct, extending into the left order branch of the both hepatic ducts, left greater than the right, and some residual dilatation of the IHBR in both liver. I have my radiologist, Dr. Shikha, joining me to give some more detailed idea about the radiology of the case right from 2024. So I request Dr. Shikha to take us through the radiology aspects of this case right from 24, and then after we can come back and discuss our further options. Dr.
Yes,
Shikha,
thank you very much. Very good evening to everyone. Am I audible, sir?
Yes, you're audible.
Yeah. If I can share my slide. I think, is it seen?
Yes, we can see.
Yeah. So actually, as sir said, this is a 50-year-old lady presented with an obstructive jaundice, and not 24. She began the disease process in May 23, and this was the first scan, first MRCP that was done, where it showed that there was a lesion at hilum, which is involving both the confluence and both the hepatic ducts as well as the proximal CBD. And the biopsy turned out negative, and she still underwent an FDG PET scan, so which doesn't show any avidity at the hilar region. And so she was continued with autoimmune or sclerosing cholangitis, or as sir said, IgG4 workup was done. And then after in June 24, again, she was imaged with MRCP. So there is increase in biliary dilatation now. Still, the biopsy turned out to be negative, and again, we did an FDG PET scan where the lesion was not showing any FDG avidity. So eventually, a PTBD was done, biliary dilatation was done, and finally, we did a FAPI on her, and where on FAPI it showed that there is a tracer uptake at the hepatic hilum. And then, sir has already mentioned that eventually biopsy turned out to be a hilar cholangiocarcinoma. This was in August 25, where a repeat FAPI was done, which showed an increase in FAPI uptake at the hepatic hilum. And then this was in December, where SUV was went down. So we said that maybe disease has been responding a little. And this is a recent that we did 2 days back, the MRI abdomen with MRCP, where still we can see that there is a residual tumor at hepatic hilum involving the confluence and proximal first order branches of both right and left hepatic ducts. So, and this was the FAPI. And of course, with FAPI, we did a triphasic CT. So we can know the exact vascular encasement, the hepatic arterial anatomy, and the portal vein. The interesting thing that we noticed with this patient, that FDG was completely non-FDG, means the disease was completely non-FDG avid on FDG PET scan, but it showed a good amount of uptake on a FAPI. So one thing that we learned with all this is that in all those tumors which show a lot of desmoplastic reaction, like pancreatic and sometimes hilar cholangiocarcinomas, they give a very good uptake on FAPI PET scans rather than on FDG PET scans. And when the imaging is done with all the triphasic protocol, then we can, in the same sitting, tell you the entire vascular encasement, whether the tumor is resectable or not. And of course, for further treatment planning also. So, if
Great.
sir,
Great points. Thank you. Thank you so
Yeah,
much.
having had a look at the radiological findings, it appears that it is an inoperable disease mostly. Very unlikely that it is an operable disease. I think they took an opinion for transplant also, and from the team concerned, it was suggested that the case is transplant ineligible. So I just wanted opinion of experts that what would be the next line of base treatment. We heard from Dr. Koyat's lecture that extra hepatic cholangiocarcinomas are also not very radiosensitive. But do you think, doctor, we should try radiation in this case with what advantages and disadvantages? Dr. Koya, would you like
Yes, I
to
think it's a
give
very
your opinion on this case?
right. If you can go back to the images, I can kind of illustrate what we would try to cover here. It's one in which
I will
we.
have to reshare.
sure.
Oh, thank you.
Yeah.
So yes, I mean, this is extrahepatic. However, there is a very, prominent component that's intrahepatic in this case. And so we would usually in this situation, go to our 60 gray in 15 fraction regimen and try to cover, this central disease as I'm outlining here, to cover the FDG avid areas and then also cover, the extrahepatic components, as it's coming down here, as well as, the regional, nearby regional lymphatics. So by getting central control here, I would expect this to, result in a, survival advantage for the patient eventually, especially if transplant or surgery are not, options on the table. That said, we also we have used external beam radiation like this as a bridge to transplant. So prior to being on the transplant list or being listed on this, we have to demonstrate disease control, usually for at least 6 months for these types of patients in the US. And so oftentimes external beam is the bridge to transplant. And we have successfully transplanted, quite a few of these patients with extrahepatic cholangio. So I think that this would be one where we would offer this, especially if surgical resection is not on the table.
Sir, if I can ask one question, how do you assess the treatment response after giving radiation to these patients? Because as we understood, FAPI will show uptake even after RF ablation, almost same amount of uptake. We won't be very confident in saying how much the tumor has responded. If the tumor has been enhancing pre-treatment, then and that enhancement is gone after the treatment, that is one way to identify the tumor has responded. But in this case, the tumor was so fibrosing, it was neither enhancing too much. So that is not that. On that basis, we cannot assess the tumor response.
Absolutely.
And on measuring the SUV also, it is so difficult to say that the disease has responded or not.
It's an excellent question. And unfortunately, I don't have a great answer because we don't know either as far as assessing treatment response, other than to say that as long as you do not see tumor growth, that indicates probably efficacy. So we usually follow the patients with serial CT scans with a biliary protocol. And as long as you get a good high resolution biliary protocol CT scan or MRI prior and after radiation, that first image after radiation serves as your new baseline. And as long as there's no growth thereafter, that means that you've achieved the treatment effect that you're looking for. These tumors, as
No
you're
progression
pointing
is
out,
good.
do not change in terms of their size usually.
Yeah, and you will prefer proton here in radiation?
So with our transplant specialists, they actually do prefer protons because that helps to spare a lot of the hilar structures that they need to, do their anastomosis. However, oftentimes we get better conformality of the high dose whenever we use, IMRT techniques, just because of the allowance for more beams and angles than you can achieve with protons. So there's a multidisciplinary discussion that we have on the choice of type of radiation.
Do you see such cases not infrequently in your clinical practice?
This is
And what
essentially
is
for
your
me,
usual experience? Yeah.
this is our usual experience, yes.
Okay,
Dr.
great.
Jable, sends a lot of these types of patients our way.
Yeah, yeah. A quick question for Dr. Wale. In absence of or beyond local radiotherapy, do you have any interesting suggestion for systemic therapy? We are likely to continue immunotherapy and do liquid biopsy periodically to find out if there is a druggable mutation emerging. But other than that, do you have any interesting ideas?
Yeah, so I think the proposal to continue the immunotherapy is the right thing at the moment. And then usually repeat ctDNA is helpful, particularly if you're already dealing with a known target alteration, because what you're looking for is resistance mechanisms developing and how that's going to influence your practice. But I did notice that on the original specimen, you said it was HER2 negative. I wasn't sure whether that was on DNA testing or immunohistochemistry. We know that,
Immunohistochemistry.
okay, because the concordance between these two, as you know, is not 100%. So I think it's always worth looking for a new targetable alteration, but I completely agree for now, continue the immunotherapy.
Great. Yeah, thank you. Thank you. I think
Thank you, sir, for a very interesting case.
yeah, thank you everybody for great opinions. We go to the next.
Thank you, sir. And that was a great case. And thank you, the experts, for all the deliberations. And we have our next talk by Dr. Nikhil Himthani. Dr. Nikhil Himthani is a medical oncologist and hemato-oncologist from the Institute of Liver and Biliary Sciences, New Delhi. Dr. Himthani has had over a decade of experience in oncology and specifically involved in the management of complex gastrointestinal malignancies, including cholangiocarcinoma and gallbladder cancers. And he's here today to talk about trial data spotlight, targeted therapy and immunotherapy, reading between the lines. And this is essentially pointing towards the landscape that we find in India and beyond. Thank you, Dr. Himthani, for joining us today. And please take us through and shed some light from the Indian perspective.
Thank you, Dr. Sevanti, for the kind introduction. And thank you, Jarurat Care Foundation. I think my slides are visible.
Yes, they are. Thank you.
So I have been given the task of discussing regarding the targeted therapies in biliary tract cancer, and I have to cover that in 10 minutes, which is a very daunting task. So as we know that cholangiocarcinoma is an aggressive malignancy of the biliary epithelium that may arise anywhere in the biliary tract. And as we know that BTCs unfortunately are diagnosed at an advanced stage, nearly 75% have non-resectable or metastatic disease at presentation, and the incidence is commonly seen between age group of 50 to 70 years and more commonly seen in females. So within the Indian landscape, the scenario remains the same. Around 18% of the patients have locally advanced disease, and around 50% have metastatic disease at presentation. And nearly 70% of the patients who are diagnosed with biliary tract cancer in India are unresectable. So as we know that intrahepatic cholangio, extrahepatic cholangio, and gallbladder cancer all clubbed under biliary tract cancer, but we have to be very all of these entities we know that behave differently with respect to their clinical behavior, their molecular profile, as well as their treatment outcomes. The prognosis is different for all, and it is very important that GBCs behave distinctly different from the cholangiocarcinoma. So the incidence in India, specifically cholangiocarcinoma, are seen more commonly along the costal belt in the and exposure to the potential carcinogens like tannin may have a role in pathogenesis. While in the northern India, mostly we see the gallbladder cancer, specifically along the Gangetic belt, and the incidence is more in states like Uttar Pradesh and Bihar. So, as we know that in the first line setting for biliary tract cancer, the treatment remains more or less the same, where combination therapy, GEM-CIS, along with the durvalumab or pembrolizumab is the standard of care. In the second line setting, precision medicine has to be followed, and we have to look for molecular markers. And as previously mentioned by the other eminent speakers, that for intrahepatic cholangiocarcinoma, the most common driver mutations which we see is the IDH and the FGFR mutation. The incidence is around 20%. For gallbladder cancer and extrahepatic cholangiocarcinoma, mostly what we see is HER2 overexpression, amplification, or mutation. The incidence is around 20% for gallbladder cancer and 15% for cholangiocarcinoma. And for these subset, the IDH and FGFR mutation is very, very rare. So this was a study which was done in India in various institutes to look at the genomic landscape of cholangiocarcinoma in India. And we can see that the most common mutation which was seen was the TP53 mutation, seen in around 36% of the patients. And among the targetable mutation, 9% had PIK3CA mutation, around 9% had IDH1 mutation, around 4% have FGFR2 fusion, and around 2% had HER2 amplification. So it is very important when to what is the ideal timing of genomic profiling. So around 20 to 30% of the patients have resectable disease at presentation. They undergo adjuvant chemotherapy, and out of that, around 60% have recurrent disease at some point of time. Around 70% of the patient have irresectable disease at diagnosis. So as per the guidelines, it is recommended that genomic profiling for looking for those biomarkers must be done at the time of diagnosis. So, although it doesn't change the management in the first line setting where the treatment is more or less the same combination of chemo and immunotherapy, but it helps us in guiding regarding the next line of treatment in the second line. So, as per the ESMO guidelines, these are the mutations which we generally test for. Mostly what we consider is for next generation sequencing testing to look out for these mutations. And the most common one are the IDH1 mutation, FGFR2 fusion, and HER2 amplification and mutation. And rest are very, very rare: NTRK, BRAF, PIK3, BRCA1, 2, and MET. So generally what we consider is for NGS testing to look out for these biomarkers. And I'll be discussing these slides in detail that these are the targeted therapies which are available. For IDH1 mutation, we have the option of giving IDH1 inhibitor ivosidenib. For FGFR2, we have the option of giving pemigatinib and futibatinib. So this is as per the guidelines which I was mentioning, that once a patient who is diagnosed with biliary tract cancer, molecular profiling should be done immediately. And although the treatment in the first line remains same, but it helps us in guiding regarding the second line of treatment based upon which biomarker do we get. So in because of the paucity of time, I'll be specifically discussing regarding the IDH and the HER2 mutation. So, in biliary tract cancer, as we know that precision medicine has come up in a big way, the field is rapidly evolving, and more targetable alterations are we are getting, and we are having a better understanding of their real prevalence. So, IDH1 is the most common which we see for intrahepatic cholangiocarcinoma. So, I'll be discussing that first. So, how do we really manage mutant IDH positive cholangiocarcinoma with focus on ivosidenib? So what is IDH? It's an enzyme isocitrate dehydrogenase, which is basically involved in converting. So I can tell you with this diagram. So IDH is a metabolic enzyme which is involved in conversion of isocitrate to alpha ketoglutarate, and that generates NADPH, which prevents the oxidative stress. Thereby leading to cellular differentiation into mature cell. So that is how the normal pathway looks like. Once the IDH is mutated, the isocitrate gets converted into 2-hydroxyglutarate, and that causes methylation of the DNA, causing blocking of the differentiation and leading to carcinogenesis. So that is how mutant IDH leads to the carcinogenesis. The idea of giving IDH inhibitor is to block the production of 2-hydroxyglutarate, which may restore the appropriate methylation state and promote normal cell differentiation. So IDH is not only limited to cholangiocarcinoma, it is seen in other malignancies as well, like AML, chondrosarcoma, low-grade glioma, as well as T-cell NHL. So this was the trial, the landmark trial, CLARE IDH-Y trial. It was international phase 3 trial, multi-center randomized double-blind. And patient who had cholangiocarcinoma with IDH1 mutation and had progressed on one line or two prior lines of treatment were randomized to receive ivosidenib 500 mg once daily versus placebo. So I think that is a sort of I would say it should have been compared with chemotherapy, where we generally consider for FOLFOX based therapy. So baseline characteristics, both the arms were well balanced, and nearly 50% had one prior line of therapy, and nearly 90% of the patient had intrahepatic cholangiocarcinoma. So extrahepatic had only 2 to 4% had extrahepatic cholangiocarcinoma. And we can see that ivosidenib, when given in either second or third line, it is better as compared to placebo, with improvement in median overall survival from 7.5 to 10.3 months with hazard ratio of 0.79. This was an interesting analysis for patient who had received ivosidenib for more than 1 year. So that was a very small subset of patient, around 26 patients. And those who received ivosidenib for more than 1 year, 92% of those patients were alive at 2 years. So there is a very small subgroup of patients who do respond well to ivosidenib. Similar results were seen with improvement in progression-free survival. The median PFS improved from 1.4 to 2.7 months. Coming on to the subgroup analysis, we can see that for all subgroup of patients, ivosidenib was better as compared to placebo, irrespective of the gender and the prior line of treatment or the performance status. Ivosidenib performed better as compared to the placebo. So coming on to the safety analysis, mostly there are grade 1, grade 2 side effect profile with the GI side effects mostly seen, like nausea, diarrhea, abdominal pain, and vomiting. It can cause ascites, which was seen in nearly 22% of the patient. Very few patients had grade 3 treatment-related adverse events, 37% versus 53%. So it is a well-tolerated drug, and the incidence of diarrhea, nausea, and fatigue were low, and the treatment discontinuation rate were also very low. So this was a study which was published in ASCO 2025, which showed the real-world efficacy and safety of ivosidenib and in US veterans with IDH1 mutated cholangiocarcinoma. And 1,000 patients with cholangiocarcinoma were taken in this trial, and 7.5% had IDH1 mutation. And out of those, 40% patients received ivosidenib. And we can see that the median overall survival in those patients who received ivosidenib was 25 months versus 8.7 months who did not receive ivosidenib. So the real world outcomes are also very encouraging. Now it is being tested in the first line setting as well. The trials are ongoing and the results are awaited. There is again one more study where after 4 cycles of Gemcis durvalumab, patients are being randomized to receive molecular directed therapy based upon the NGS profile versus the standard of care. Again, this is an ongoing trial. So coming on to the second line treatment for HER2 as a target. So we know that HER2 is a protein that controls the cell's development, and HER2 can become either amplified or overexpressed. So amplification is at the DNA level where there are extra copies of the HER2 gene which encode for HER2 protein. Overexpression is basically when the HER2 protein is overexpressed. So in either of the cases, it can lead to carcinogenesis. And the proportion of HER2 positive biliary tract cancer, as I've discussed, the incidence is more in gallbladder cancer, around 20 to 30%, while for extrahepatic cholangiocarcinoma, the incidence is around 20%. It is rare to see HER2 mutation or amplification in intrahepatic cholangiocarcinoma. It's around less than 5%. So how do we really test for HER2? It is generally done by IHC, and the guidelines are same for stomach cancer, where a 3+ score is considered as positive and 0 and 1 is considered negative. And 2+ is inconclusive. In such cases, we have to do FISH, and if it's gene amplified, then it is considered as HER2 positive. So there are different methods to assess HER2, and it is recommended that both NGS and IHC should be done because there is discrepancy. So this was a study which was done in stage 4 biliary tract cancer in around 300 patients, and both HER2 testing was done through NGS as well as IHC, and it was seen that 15% of the patient who had HER2 negative disease by NGS actually had HER2 positive disease on IHC. So there is a 15% discordance, and therefore it is important that both NGS and IHC are necessary to accurately evaluate the HER2 status. So treatment options, we have multiple options, although there is no single standard of care, but there are multiple options. Either we combine trastuzumab with pertuzumab or trastuzumab with tucatinib. And as per the Destiny trial, there is option of giving trastuzumab deruxtecan for IHC 3+ disease. And recently we have a newer drug by the name of zanidatamab. We will be discussing that. So this was the My Pathway phase 2 trial where around 39 patients with HER2 positive biliary tract cancer received doublet anti-HER2 therapy, trastuzumab with pertuzumab. And we can see that overall response rate was around 23% with median duration of response of around 10.8 months. Median overall survival was seen around 10.9 months. Similar results were seen with another trial. This was again a phase 2 trial, and combination anti-HER2 therapy where trastuzumab was combined with tucatinib. It's a TKI which acts on the intracellular pathway. Again, patients who were previously treated and had HER2 positive disease. So we can see the overall response rate of around 46%, median duration of response around 6 months, and median overall survival of around 15 months. Similar.
Dr. I'm so sorry. I think we are really over time. Your presentation is great. And as you just said, cholangiocarcinoma is really with multiple options of targeting. I think it would really suffice if you could give the final ballpark of what we end up doing, what are the drugs that are available in India, and what are we importing still, and whether we have these trials. Just a few sentences on that would be really reflective.
So yes, so I would conclude that for advanced BTC, we know that in first line chemo as a standard of care, but molecular profiling must be done to look out for these driver mutations. And as we can see, as per the ESMO guidelines, we must look for these mutations. For IDH1, we have the option of giving ivosidenib. It is recently available in India. For FGFR2, we have the option of giving futibatinib and pemigatinib, which are not available. BRAF, we have the option of giving dabrafenib and trametinib. HER2 overexpression, as I was discussing, we have multiple options, either trastuzumab with pertuzumab or trastuzumab with tucatinib or TDXD. These are all available. And there is recently newer drug, zanidatamab. Again, this is, I think, not available in India, and as of I have not used. And NTRK, again, this is tumor agnostic approval for entrectinib, larotrectinib, and repotrectinib. And for RET, we have the option of giving selpercatinib. So I think precision medicine is going to play a major role in advanced biliary tract cancer. And I think sooner or later, they would be incorporated in the first line setting as well. So with that, I can conclude and thank you.
Thank you so much. I think this was truly a Herculean task. So very well spoken, I have to say. And I was really wanting to listen further. This is a very interesting topic, and especially when you consolidate it and summarize in such a tight time, it becomes even more interesting. And one wants to quickly get up to speed with a lot of facts. What the last slide told me, though, which I would really like to underline here, is that many of these targeted therapies are available in India. We really need to be cognizant that this is a disease that has so many different faces. And unless we test, we are not going to find these options. And to test early is the bottom line, because then you are prepared and you also help prepare the patient, the family, but what kind of expenses to look out for, and also look out for trials ahead of time. Because as we all know, trials are not that prominently present in India. Some of these patients actually even wish to travel in the Asia Pacific region to participate in novel drug studies. And so knowing the pathways early on, knowing what is available in India, and then making that available for the patient is a responsibility of a leading clinician. And I think it is truly awareness and orientation. And that's what your last slide and the bottom line was. And I think that is a message, that is a great message that I would like everybody to take from here further. So thank you so much, Dr. Nikhil, for your presentation. And now we have the last presentation of this evening. Dr. Deepti Sharma is a radiation oncologist at the Institute of Liver and Biliary Sciences, and she has specific expertise in managing complex liver and biliary tract cancers, including cholangiocarcinoma. And she is going to give a reflective presentation on radiation in cholangiocarcinomas in the Indian scenario. And thank you so much for joining us. Dr. Deepti, please take it forward. Thank you.
Yeah, good evening, one and all. Greetings from ILBS New Delhi. So at the outset, I'd like to thank the organizers. And today's topic for me to present is radiation evidence under the microscope, what justifies escalation in intrahepatic cholangiocarcinoma. So this will be my outline for the next 10 minutes and so. So as we all know, the factors like environmental, viral hepatitis, primary sclerosing cholangitis, PBCs leads to mast cell and CLD, which in turn leads to intrahepatic cholangiocarcinoma. The incidence is increasing in the last 15 or 20 years and so. The incidence is not only increased in the elderly, but also in the younger age group. If we talk about the treatment modalities as per the staging, whether resectable, locally advanced, or metastatic. So the treatment is either surgery or locoregional therapy and systemic therapy. So overall, a multimodality treatment is required. Now, going from ABC02 to Topaz 1 and Keynote 966, the median overall survival ranges from around 11 months to 13 months. So how we can improve the overall survival, and is there any role of locoregional therapy? So for that, and why the survival is less. So in this study, this is already presented by Dr. Coy, that in intrahepatic cholangiocarcinoma, 83% of the mortality is due to either biliary or vascular complication. So if we control the local disease, it will result in improved quality of life and prolonged survival. Now, another study by Yakashita et al., they found that the patient who underwent resection or radiation therapy, they have a better disease-specific survival, and also the death related to the liver failure was statistically higher in patients who receive chemotherapy as compared to those who underwent resection or radiation therapy. So that is the point, that is why we require a loco-regional therapy. Now, the loco-regional therapy selection criteria depends whether the lesion is small or large, whether it is hypovascular or hypervascular, and its location in the liver. And if we talk about the SBRT, the SBRT is a procedure which can be used irrespective of the anatomical location, vascularity, and the tumor size. Although we need to look at the liver function test, remaining liver volume, distance from the bowel. So SBRT is already discussed. It's a highly conformal radiation therapy with high dose per fraction. We need to take care of the organ at risk. This has already been discussed. So in this SIP trial study, what we have to do is we need to give very high doses to the center of the tumor and at the periphery of the tumor to reduce the doses to the organ at risk like bowel or liver. We can reduce the doses to the PGV. This is what is known as simultaneously integrated boost with simultaneously integrated protection. And in this study, the Tao et al. Have demonstrated that the patient who receive a higher dose of radiation therapy with a higher BT, they have better overall survival and local control. Another way of escalating the treatment, how we can immunomodulate the radiation, the tumor microenvironment, is by using radiation therapy along with the systemic therapy. So when we give chemotherapy or targeted therapy or immune checkpoint inhibitor, it results in DNA damage, apoptotic cell death, inhibits angiogenesis, neovascularization, and immune checkpoint inhibitor results in enhanced T cell activation. When we give radiation therapy, it results in immunological cell death, increase in tumor-associated antigen release, increase in TNF type 1, which in turn results in activation of dendritic cell, priming of the tumor-associated antigen-specific cytotoxic T lymphocytes, and in turn, our cold tumor gets converted into a hot tumor. So this is the principle why we can use a radiation therapy along with the immunocheckpoint inhibitor and systemic therapy. Now, how we can use, what should be the way out where radiation and therapy and systemic therapy can be used in combination. So it can be used as a downstaging procedure to resection or liver transplantation, as a consolidative and palliative. So in this study by Sumiyoshi et al., the chemoradiation therapy, patients were treated with neoadjuvant chemoradiation therapy versus chemotherapy alone. And they have found that out of 15 patients, 11 patients underwent radical hepatectomy post neoadjuvant chemotherapy, and those patients who underwent neoadjuvant chemotherapy and radical hepatectomy, the overall survival was statistically significant, 37 months versus 10 months. This is one of the patients that we have treated in FAB 21 with JAMK-based regimen, followed by radiation therapy. Later, portal vein embolization was done, and finally the surgery was done, and patient is doing good at this point of time, for approximate 5 years down the line. Now, SBRT can be used as a neoadjuvant modality. In this study by Sanders et al., they have included 31 patients, out of which intrahepatic cholangiocarcinoma was 6. A dose of 40 gray in 5 fractions was delivered. And out of these 6 patients, 4 underwent liver transplantation and 1 had dissection. Again, the overall survival in the patient who underwent surgery was statistically significantly higher of 31.3 months versus 13 months. Another patient that we have treated, the hyalocholangiocarcinoma, we've given the chemotherapy followed by radiation therapy. Here, in this case, we have given radiation therapy in 15 fraction, followed by liver transplantation. So again, radiation therapy along with the chemotherapy can be used as a neoadjuvant procedure to liver transplant. Another patient that we have treated with SBRT, followed by systemic therapy, and later live donor liver transplant was done. Although this is a patient of intrahepatic cholangiocarcinoma, hepatocholangiocarcinoma. Now, this was already being discussed by Professor Coy, where ablative liver radiation therapy is being used for unresected resected intrahepatic cholangiocarcinoma. And again, the authors has demonstrated that the patient who underwent ablative radiation therapy along with the chemotherapy, the overall survival was the median overall survival was 24 months, which was statistically significantly higher as compared to conventional RT or chemotherapy alone. This is a study that we have published from our institution, SBRT in advanced intrahepatic cholangiocarcinoma. Although it's a retrospective study with small data, 17 patients, viral hepatitis was there in 6 of the patients, large tumor size of 8 centimeter, ranging from 4 to 14 centimeter. At the baseline, locoregional lymph nodes were there in 64% of the patients, satellite lesions were 82. Neoadjuvant therapy was given in 30% of the patient, and adjuvant therapy was given in 82% of the patient. The median overall survival in this 17 patients from the day of starting chemotherapy was 21 months, and median OS from the day of SBRT was 17 months. The median local control was not reached, and the median progression-free survival was 10 months. The out-of-field intrahepatic metastasis and lung metastasis occurs in 10 patients during the follow-up. This is one of the patients just treated in December 2019. We started with chemotherapy, followed by SBRT, 50 grain 5 fraction to the GTV, followed by maintenance capecitabine, and this is a follow-up scan of in October 25, and patient is NED as of now. This was already discussed, study by Day et al., where SBRT is used in the metastatic intrahepatic cholangiocarcinoma with radiation therapy in one of the arms along with the chemotherapy, and the median overall survival was 9 months in the patient who received chemo only, as compared to 20 months in the patient who received radiation therapy along with the chemotherapy. So again, another patient that we have treated for intrahepatic cholangiocarcinoma along with the lymph node metastasis received SBRT to the primary as well as the lymph nodes area, followed by chemotherapy, and this is a follow-up scan after 1 year. Another patient of intrahepatic cholangiocarcinoma presented with bone metastasis at baseline. We started with SBRT because due to the bone metastasis, patient was having symptoms. And we started with radiation therapy at baseline, followed by chemotherapy, gemcitabine plus cisplatin, and followed by maintenance capecitabine. And this is a follow-up scan of July 2025. Now, SBRT can be used along with the chemoimmunotherapy. And in this paper by Asif et al., they have found that the median overall survival in the patient who received SBRT for chemoimmunotherapy along with the SBRT, the median overall survival was 17.4 months, and there was no grade 3 and grade 4 reaction, suggesting that SBRT can be safely given along with the immunochemotherapy. So I'm just skipping because of the shortage of time. In this meta-analysis published in 26 this year only by Lee et al., again they have found that the patient who has received dose-escalated radiation therapy and those who have received chemotherapy along with the radiation therapy, they have better overall survival as compared to chemotherapy alone or reduced conventional dose radiation therapy. And NCCN has also included the role of SBRT in intrahepatic cholangiocarcinoma. To conclude, RT is associated with prolonged overall survival in retrospective studies, require phase 3 and RCT to demonstrate role of radiation therapy with chemoimmunotherapy in advanced metastatic intrahepatic cholangiocarcinoma. So at the end, I like to say that radiation therapy is a ray of hope for intrahepatic cholangiocarcinoma. Thank you.
Thank you, Dr. Deepti. Wonderful presentation and multiple cases that you showed. I think after Dr. Koy's lecture and yours as well, where you showed so many cases, I think the message is loud and clear we have to look at the cases with the lens of where this radiation application would be meaningful. And specifically when we have intrahepatic cholangiocarcinoma or extrahepatic with limited disease volume, we have to look at role of radiation, and we have to also be cognizant of a good center, like the kind that Dr. Deepti presented, or I'm aware that at our center, very high level radiation oncology planning is performed. And, we also outline proton centers. I think that is the message. We have to reduce the toxicity, and we have to enhance the control as we offer radiation to select patients. And multidisciplinary involvement is the main message, where people can bring in their body of expertise and help enhance the outcomes for these patients. I think we are really getting closer to ending the meeting, but before we get there, very quick questions for our experts, and also open to the forum for any specific questions they have. But I have just mulled over some of these questions, and one is a very basic question. I'll take this to Dr. Coy. What would be the best imaging at this time, for focused treatment? And since you are the definitive treatment person, CT scan, MRI, FAPI-based imaging, FDG has been there. And what do you do in your routine practice?
Our usual practice is to use a liver protocol or biliary protocol CT scan with contrast. Recognize that sometimes actually it depends on the institution and what your medical physics and imaging physics groups have developed for you. So definitely, recognize and respect that sometimes PET and or MRI may actually be better at a given institution for imaging. I think it's really an institution-specific decision about where you put your resources and what the imaging modality is. The key is that you're able to see the tumor in high resolution and delineate it specifically so that you can, treat what is truly disease and spare what is normal tissue. So we use CT scans routinely here, but there are some patients where an MRI does add a lot of value. So it is a patient-specific decision also.
Great. Thank you for commenting on that. And now the question for Dr. Wale. We heard from Dr. Talati regarding his case, which now probably will receive some radiation. What would be the role of liquid biopsy? We heard about potential role of liquid biopsy in early diagnosis. In routine treatment, what is the role of liquid biopsy that you see in being practiced already, and what is futuristic as well?
Yeah, thank you for the question. This is something that we're trying to address as a foundation in the setting of something that's constantly changing. The technology for DNA, NGS, RNA, and then protein keeps on changing. So what we have done, we've joined with the Pancreatic Cancer Action Network, PanCan, and together we're developing a manuscript to address this particular question. I think the key take-home message is that the baseline assessment needs to be comprehensive biomarker testing with whatever is available at the time. In 5 years, it may be different. But what we mean by comprehensive in 2026 is good DNA, good RNA, and protein testing. So this includes both tumor and liquid. We've had quite a bit of debate about the importance of then repeating this on disease progression. And that probably depends on what biomarker you're looking for. So we know, for example, that patients who have an FGFR targeted therapy are likely then to develop resistance mutations, sometimes in pathway, sometimes out of pathway. So the more we learn about this, the more important it is to then repeat the sample, which could be tumor or liquid, to see if any resistance mechanism has developed, because that may help to inform what your subsequent treatment is. If there is no alteration, there may not be so much value in repeating this sequentially. Specifically, we're looking for additional treatment options. This applies to patients receiving targeted therapies. But the key message is, at baseline, good comprehensive biomarker testing is important.
Great. Thank you. Thank you for that input. Just for Dr. Talati's case, we recently treated, I think around, I would say around nine months back, we treated a patient, a very similar patient, and that patient received SBRT. And prior to SBRT, we were able to biopsy this patient, profile the patient, and we did a Signatera, which we then used to track this particular patient. So tumor informed versus tumor agnostic, and a lot of options emerging. And of course, we know the options are wider in the US with more sensitive tests emerging like Polaris, and the whole data out there regarding whole genome sequencing informing liquid biopsy tracking. So I think a lot to look out for. And since we are truly at the hour, my last question back to Dr. Toya, where my question is regarding SBRT versus liver-directed nuclear treatment. How do you choose between
so liver-directed nuclear being like
TACE
Y90, TACE or TARE, right?
Yeah.
It's a good question. Yeah,
when we look at liver-directed treatment, a lot of the experience actually comes from treatment of HCC.
Yes. So for intrahepatic cholangiocarcinoma, show that there is a dose response and some excellent outcomes for selected patients with intrahepatic cholangio receiving SIRT or Y90. So those are very encouraging, and actually the median survival times are similar to what we report with external beam radiation. However, it's very important, just like with external beam radiation, the technique matters. We know that there's a dose response with external beam, and similarly with intrahepatic cholangio, we expect that there's a dose response in terms of the Y90 dose that you deliver. Oftentimes in the community with Y90, you're injecting what's called an activity, which is not the dose that you're delivering to the tumor. You have to calculate the dose of radiation from the Y90 in the tumor after you've injected some, test dose. So there's dosimetry that has to be done, and only certain centers are able to do this right now. It's not something that's readily exportable or widely available throughout the globe. So as long as you can calculate the dose and ensure that you're meeting a dose that is ablative for that tumor for a given patient, I think it's a very good option. However, unless you have that, if you do not have that, then it may not be the best option for a given patient.
Yes,
sir. Can I have for FAPI positive metastatic disease? What is the experience of isotope treatment?
Yeah, that's a good question. I'm not sure I have a great answer. Juan, do you have any thoughts on that?
I was just wondering, because we see often FAPI positivity in these tumors. Why can't we exploit it with isotope treatment?
I would love to see studies with that.
Experimental, sir, and we are seeing some of that happening in India as well. I think that field remains to be informed. But wonderful question. And I think great inputs from our experts and also our national experts. And thank you so much. I bring it back to Priyanka. Priyanka, last words from you.
I think thank you so much. I think this was a very, very informative meeting, and I'm very, very thankful to all the speakers, Dr. Sevanti and all everyone, the entire Jarurat Care team to make this happen. And that's all from my side. But I think before we close, we are very ahead on like past time. The team will just click a picture if everyone can please turn on their camera so that we have a group memoir together and many more to come in future.
Sure.
Siddharth, yeah. Siddharth, you are taking it, right? Yeah.
Yeah, I'm taking.
Yeah, I think, yes. We are done. That's all. Yeah. Thank you so much, everyone, for joining in on a Saturday evening with us.
More power to you, Priyanka. And thank you, Dr. Ali, Dr. Koya. Thank you so much, all experts, for joining us and all the attendees. Thank you.
Thank you. Thank
My
you.
pleasure.
Bye-bye. Thank you,
Take care,
everybody.
everyone. Thank you.
Great evening.
Bye-bye.